Oh, to be young and have so much energy. Oh my God. Passion. You know, there's 4 P's you need to think about. Passion, pursuit of knowledge. Um, let's see, the third one is passion, pursuit of knowledge, solving the planet's problems. And, huh? I'll think of it, but you got them all. So that was great. This is kind of a painting that Jack Winberg started back in 1973 in Science that many of you are probably familiar with. And I'm just stand on Jack's shoulders. I was fortunate enough to follow him as the director of the Dartmouth Institute for a while, worked on Atlas projects for 20 years. I'm still a practicing spine surgeon to get into the spine surgery debate. Now I actually run a health system because Jim Kim, who was at Dartmouth, said, you know, you need to run the healthcare system, Jim. And then, of course, he went to the World Bank. So, you know, life continues to be a lot of stories. I would just say time, the word time. Everybody's in a rush right now. I think what's happening is so exciting, and we shouldn't be disappointed. It took Jack, you know, over 40 years for people to actually listen to his writings and talk about getting accepted to journals. New England Journal would never accept his work in the beginning, or JAMA. And you know, it's probably the most important work in us actually starting to think about what we need to do in healthcare. So I'm a product of that. This map just says that there's threefold variation in the spend for Medicare patients. You're all familiar with this. And it really, the story really begins in clinical practice. You know, how do you actually do this? There's a lot of questions to people like Brent who make it sound so easy. It's not easy. I've been trying to do it, like many of you, for my whole career, and it'll never sound as good as Brent James, I promise. Yet I've been able to use data at the point of service to take care of my patients with real data, whether it's the SF1 that was talked about or the SF12, whatever version you want. We collect that, and now, because I am the CEO, we do it for every patient in the system. That's the advantage of being the CEO. And the issue is that I thought it was important to have the patient's voice, has been discussed here many times, because when you're talking about ethical and moral issues, it's not just your practice issues, and we have those challenges within the profession, but it's the patient. I'm the father of who lost a daughter at age 12 to cancer. For 12 years, she went through chemotherapy and radiation. And oh, by the way, sure, it was all about the patient, but everything she was on was all about research. Nobody knew what to do for her cancer. And so I understand from the patient side, from the parent side, from the physician side. And then I'll tell you that I ran a trial for NIH, which is still going on, called the SPORT trial, Spine Outcomes Research Trial. We did it in 11 states. It was actually one of these trials I really wanted to do where we actually had an RCT side by side with an observational cohort. Because one of the questions was, how do RCTs actually relate to observational cohorts? And are we spending so much money doing randomized trials we don't really need to do? Because then I wanted to jump it up to the Atlas level with millions and millions of lives, which gets to this high-value healthcare collaborative, which I'll discuss. So we did those trials, and we had all the IRB issues, because every state has their own IRB laws, of course. And can you do a central IRB? And, you know, we can all tell those stories. But the point was that we were able to do it. What we really found and published in JAMA and New England Journal was really the RCT wasn't that much better than the observational trial. There were some differences, but the differences were not significant in many of the diagnostic groups. And we have a large component of patient voice in that to actually look at cost effectiveness and all those technical things we do as scientists. But at the end of the day, what I know from our shared decision-making center is that patients have a lot of decisional regret when we don't involve them in the decisions. So our breast cancer population, do you do lumpectomy versus mastectomy? Well, you know, we actually got laws changed in California, and the state of Washington actually picked this up a lot because of Jack and others, to actually mandate shared decision-making for patients so that they could have an informed choice. The doctrine of informed consent is really about assault. I don't believe any doctor actually wants to assault a patient. But that's the legal doctrine of informed consent. We actually would like to see that be informed choice. It is the patient actively involved with the patient in making those decisions. That said, I said, well, how do we spread this nationally so everybody can be part of it? And I believe real reform has to occur at the system level, not at the federal level. Federal level should support those things and allow us to do those changes, but good people with good intentions can make real change. And this issue of disparity and inequity is huge. You know, most of the hospital systems in America are not Intermountain, they're not Mayo Clinic, they're certainly not Dartmouth-Hitchcock. And that voice has to be heard and has to be involved in these trials. Most trials, you never really know what the denominator of the population substrate was that they actually could have enrolled. They don't write about it, and you just have what they actually show you in the article, which is limited. So we went out and started this high-value health collaborative with Mayo, Intermountain, just because we've been working together for so long, and Jack had been working with them for a long time. But I said, you know, we need to bring in Denver Health, people like Ed and Patty Gabow. We need to bring in Sinai in Chicago. These are safety net hospitals. We actually pay for them to be involved. They pay no fee to be involved in the high-value healthcare collaborative. Each system pays about $200,000 a year to participate in this. So if they're not seeing value in it, CEOs like myself would say that's not in the budget. We got enough trouble trying to stay with the budget. I think the issue with healthcare reform or health, whatever we want to call it, chaos right now, most systems are really struggling. And I didn't hear that enough today. But I would tell you most physicians are struggling. They are not happy. They went into medicine to practice medicine, to take care of kids like my daughter or see patients like I do in clinic. They didn't go in it to try to figure out how many clicks they could do on a computer, how many RVUs they could generate to keep the system sustainable. So we've got this all wrong. Imagine a glass in front of you today filled with orange juice halfway. All of you would say it's half full, half empty, at least most of you would. But really, to me, that's the wrong glass. And I think we've been looking at the wrong glass to think about solving our problems. And yes, informed consent is important, informed choice, whatever you want to call it. But gosh darn it, we need to share information so we can all get better. And when I say all, I mean all across systems. And the rich should help the poor, and the poor should help the rich, because I've learned more from Denver Health than I have from many other systems across the collaborative. And so I would just say that this idea of how you structure things, how you enroll patients, the structure for this collaborative, we created a master collaborative agreement. We spent about $250,000 on lawyer fees. That's cheap, right, for lawyers. And about 2 years, so that now we can collect data from the electronic medical record, all the claims data, all payers, all patients, and including data from the patients through one legal document. So anybody joins us, we can share data with. We have a data repository. We have 40 million records we get every quarter. We have EMR data from all the systems of selected input. And I think it's just all possible. And the final thing I'll say is, depending on the system you're in, when people say it's hard, if you're in a health plan, you need to enroll live so you have the opportunity to get the first dollar of the premium. When you don't have a health plan, you're working with multiple health insurance companies, which is very complicated. They have very different contracting. And so people avoid the issue that money drives a lot of things, and I think we can't do that. We have to have the honest discussion. A part of the interference in doing really good work is that money has become such a problem for a healthcare system that's quite bloated with over 5,000 hospitals, many just wanting to survive. And that issue we have to take on as a nation, not as individuals. And I hope that we can start to create more collaboratives that I've heard about today, whether it was in children's with Cincinnati or the work by the HMOs and about the private health plans is very encouraging, and the PCORI work certainly is outstanding, but we need to share this data to make patients better, and we need to have patients in these rooms when we have these discussions. I think that's the voice that's missing today. Thank you for the time.